It's first. Hello, everyone. Thank you all for joining us today. For those of you who don't know me, my name is Nick Hubda, and I am a chief resident of the University of Washington, Boise psychiatry residency program. And it is my privilege and honor to introduce today's Grand Round speaker, Dr. Elizabeth Goss. Dr. Goss obtained her bachelor's degree with a major in biochemistry from North Carolina State University before obtaining her MD and MPH from the University of North Carolina at Chapel Hill. After medical school, Dr. Goss completed her psychiatry residency at the University of Washington. She then immediately completed a fellowship in consult liaison psychiatry, also at UW. Dr. Goss then obtained additional fellowship training in forensic psychiatry at the highly respected Albert Einstein Montefiore Medical Center Forensic Psychiatry Fellowship Program in New York State. She has since held positions as a clinical instructor with the University of Washington Department of Psychiatry and Behavioral Sciences, as an adjunct professor of psychiatry at Idaho College of Osteopathic Medicine, and has worked in various hospital settings in Washington State, New York, and Idaho. She is also a published author in multiple publications, including JAMA. Currently, she practices psychiatry at West Valley Medical Group in Caldwell, Idaho, and works some in her private practice. She also serves as a psychotherapy supervisor with our Boise Psychiatry Residency Program and was voted Best Psychotherapy Supervisor by residents last year. We are honored to have her today to present on a topic that is highly relevant to psychiatry and psychology, titled Violence Risk Assessment. So please unmute your microphones and give a warm welcome and round of applause to Dr. Goss.
Yay!
Thanks, Nick. That was very generous. And thank you for inviting me to give this talk. And thanks also to Nikki and Heather, as always, for making everything work so smoothly behind the scenes. So I wanted to talk today about violence risk assessment. And here's what I'm hoping to get through. So I want to talk about risk assessment in the context of a case. So I'll present the case first, and then I'll go through an overview of the different types of risk assessment as I view them, and also consider the goals of risk assessment. And in doing that, I also, in the spirit of providing some forensic didactics, review the relevant case law and Idaho statutes. And then I want to take some time to describe the limitations of risk assessment. And then we'll go back and try to apply some of those principles to the case I'm about to describe. And if we have time, we can discuss as well my thoughts about the future of risk assessment, which is an area where I've done some research. All right, so to start out, this is a case based on a patient of mine who I've changed some details in the interest of de-identifying the case. But this was a 24-year-old.
Yes, I'm going to put you on speakerphone here real quick. There's no one else in the room, though, just so I can take some.
Dr. Litchfield, I believe
yes,
you're
I recall him, and then I spoke with
Let me
Joe
see if I can get that taken care of, Dr. Goss. So sorry.
Yeah.
Zoom.
Yeah, so I had just called to reschedule an appointment because we have one today, but then Dr.
Okay, so 24-year-old guy who presented to my clinic to establish care really for depression. He had been in psychiatric care previously, but not recently, and his past diagnoses had included major depressive disorder, autism spectrum disorder, and possible cannabis use disorder. He had no significant past medical or surgical history, but his past psychiatric history was notable for one past suicide attempt that had been about 5 years prior to him seeing me, that had resulted in a voluntary psychiatric hospitalization for about a week. He then had 3 years of therapy. I actually think about a year of that was prior to that episode, and several years were after that, with a couple of different therapists. And he had one past SSRI trial, which he had found helpful, but he stopped because he moved and fell out of psychiatric care. He had no legal history. His social history was notable for late talking. He had some behavioral problems in school leading to an IEP, but he was able to complete high school. He had not attended college. He'd successfully held a number of retail and food service jobs, usually for about a year or two at a time. following his completion of high school. He's currently living with his mother and older brother and denied any significant long-term friendships or romantic relationships. In terms of his substance use history, he reported occasional alcohol use in moderation, 2 to 3 drinks, usually about once a week. Never any significant history of binge drinking or alcohol dependence. However, he'd been using cannabis 3 to 5 times a week for about a year at that point, and prior to that, it had been about 1 to 2 times a week. He had started using cannabis when he was about 18 years old. All right, so again, he was presenting to establish care for worsening depression, and when I first met with him, he described experiencing significant anger towards people, especially women. And his main frustration is that they often seemed not to reciprocate his attention, or he would struggle to connect with them. He would really try to form friendships or romantic relationships. And he said, I ask all the right questions. I know what I'm supposed to do. I know that I'm supposed to, look them in the eye and ask them about themselves. And it just seems like they're never interested, or they're initially interested, and then it doesn't pan out and they don't want to talk to me after a few conversations. And he was really frustrated about that. And he actually cited that as one of the primary reasons for his worsening depression. In terms of screening for depressive symptoms, he reported hopelessness, apathy, amotivation, hypersomnia, some anxiety, which he attributed to the depression, didn't really have it baseline, irritability, reduced appetite, and intermittent passive suicidal ideation, but no active SI or plan. He denied current or historical symptoms of mania or psychosis. And in the course of talking about his symptoms, he told me that he often fantasized about hurting his ex-stepfather, who lived in another state. And he told me that he would never act on that, and he had no intent or plan, but this had been something he had been sort of stewing on for a long time. So it was a bit of a complicated social situation, but essentially his ex-stepfather was the father figure who raised him. And that person had since separated from his mother, who he was currently living with, but he still had some contact with this person and felt very angry towards him and frequently fantasized about attacking him or hurting him in some way. All right, so having that that history, is there anything right off the bat that you guys would want to know? Feel free to unmute yourselves and offer any sort of follow-up that you would want to ask at that point. Or if you prefer not, we can kind of come back to this. So just kind of think about how you would.
I would investigate just his guns and weapons and that sort of thing.
Yeah. So Steve, that's two really great points. So guns, any history of access to weapons or previous use of weapons. Yeah, agreed.
And the other thing that I do a little bit is I want to find out, what his media intake is. And sometimes people just have regular violent shows. And then sometimes people have like pretty sick stuff. And it's like, wow.
Yeah. So yeah, what kind of media he's consuming, where his attention is. Yeah, agreed. So think, for the rest of you guys, think about other avenues of questioning you might want to pursue, and what your framework would be at this point for sort of next steps in your risk assessment. Because if you're like me, and you're sitting in the room with this patient who's disclosing this to you, I started to feel a little bit anxious and started to think, okay, what do I need to ask here? How do I need to kind of move forward to make sure that I'm doing the right thing for this patient and anyone he might hurt? And hopefully by the end of the talk, you'll feel like you have a little bit more of a formal framework for doing that, although many of you guys probably already do. So to provide some context for that, let's talk about risk assessment generally. And I'd like to start with what I think is a pretty helpful definition that was outlined by Kramer et al. Back in 1997. So they defined risk assessment as the process of using risk factors to estimate the likelihood, in other words, the probability of an outcome occurring in a population. And risk factor here is defined as a correlate that precedes an outcome in time. And you'll notice that that's a very careful definition that avoids assigning any causality to these variables, because we really don't know about potential causality. We just know that there are variables that we can identify that are frequently associated with violence. And there are two main kinds of risk assessment. They're really probably best conceptualized as poles at the opposite end of a spectrum. There's really a spectrum of tools, but at one end is clinical risk assessment, which is sort of our clinical gestalt and what we most often employ in our practice day-to-day seeing patients. And that is really similar to what we most often do for suicide risk assessment. So in other words, it's our best assessment and synthesis of the data that we typically gather in a psychiatric interview, and then presentation of that in sort of a semi-structured way to estimate a degree of risk. And on the far other end of the spectrum, and in contrast to clinical risk assessment, is what's called actuarial risk assessment, which is what we most often employ in forensic settings. And so to understand actuarial risk assessment, I think the best way to think about it is to conceptualize it really as a statistical model. So in other words, in an actuarial setting, you're gathering a lot of data, usually in a fairly formal and structured way, and then you're putting that into a statistical model to produce either a numerical or a categorical estimate of risk. So in other words, a number, a probability of outcome, the outcome of interest, which is usually violence, which we may define in some more or less specific way, or a risk level, so low, medium, or high. And actuarial models actually do employ sort of statistical algorithms or the use of an actuarial table. And I'll come back to that in just a second. But to provide a little bit more context for that, and when you're trying to decide what might be the most appropriate tool to use for a given setting, I think it's helpful to keep in mind the goal of your risk assessment. So in a clinical setting, what we're usually trying to do is to assess imminent risk and then determine an appropriate level of care. And in addition to that, we're often trying to identify, just as Steve was just alluding to, modifiable risk factors for violence, things that we can target in our clinical practice and then intervene on to help the patient have a lower risk of violence. And we usually do that in the context of a formal violence prevention plan, just like a suicide prevention plan. That's for us as clinicians. In forensic settings and for the courts, often the goals are a bit different. Usually the courts or forensic evaluators are trying to understand both acute and chronic risk. So risk often over a longer time horizon, which you can imagine makes more sense if you're trying to make a decision about, for example, what's the appropriate level of supervision for someone who might be incarcerated and is considering, being considered for parole, for example, or if you're thinking about someone who's currently forensically hospitalized and maybe has been contained in a forensic setting for years and you're thinking about releasing them back to the community, you might want to synthesize that data in a more formal and structured way. And so again, for clinicians, we're usually using clinical risk assessment, and for courts, they're usually using one of these actuarial or statistical risk assessment tools. And I want to focus mostly in this talk on clinical risk assessment and how we should approach that and how we best can do that. But I do want to talk a little bit about actuarial risk assessment, just because I think it's helpful to know about and also probably provides a little bit of helpful context for us when we're conducting our clinical risk assessments. So I mentioned that these tools are usually created using fairly sophisticated statistical models. So usually what happens is there's research that synthesizes a lot of data, and statisticians in conjunction with clinicians will create these complex models that utilize certain variables that are found to be related to violence risk and then assign them certain weights within the model. And then a rater, which could be either the patient or a clinician, will go through and rate the presence or absence or degree of presence of each of these variables and feed that into a model. And then that will determine the patient's categorization in terms of their risk. And for comparison, you can see here I have an actuarial table. This is a Social Security table that estimates someone's probability of death based on two variables, their gender and their age. So these tools have been in use for a long time in a variety of settings. The outputs of note in these tools are, as I mentioned, often either numbers or a certain level of risk. And that can be helpful, but it's also worth noting, and I'll come back to this in the limitation setting, that this is a population estimate that we're looking at. And just to kind of help you get your head around this a little bit more, if this is not a concept that's super familiar to you, this is the same approach that insurance companies use when they're trying to decide what your life insurance premium will be, right? So if you're applying for life insurance, they're going to want information about your comorbid health conditions and your history, and then also your health-related behaviors. And they're going to feed that into a model that is going to give them an idea of your estimated life expectancy. And so if you, for example, are a smoker, then they're going to assign you a higher level of risk. In other words, they're going to know based on their modeling that you belong to a population of individuals who are more likely on average to develop lung cancer or other smoking-related medical conditions and therefore die at an earlier age. That doesn't actually give them any information about your individual likelihood of dying of lung cancer. They can't foresee that even with the best statistical model, but they can know that you belong to that population. And then they can adjust your premium on that basis. And so actuarial modeling for risk assessment really operates in a similar way. The reason I have a coffee can here is because even though those tools, as you can probably tell from the way I'm explaining them, are much more sophisticated in how they're developed, and they often require the use of a lot more data, both to develop the model and then for the individual in question when you're applying the tool, there's a ton of information that you've got to gather. So you would think that they would be more accurate, but the evidence is actually fairly mixed about whether they are in fact more accurate than our clinical gestalt. And there have been some interesting studies. So there's no great head-to-head comparison of actuarial tools on the whole versus clinical judgment, structured or unstructured. And so there hasn't ever been a definitive study that can really speak to that question. But there was an interesting study back in 2005 where a bunch of researchers took a bunch of variables that we know are related to violence risk, things like, patients' history of violence, for example, or their substance use, and put them all of those variables in a coffee can, and then created a few different tools where they just pulled out some random variables and mashed them together and made each of those a tool, and then compared them to each other and to existing actuarial tests that are in common use and have been validated in a number of settings. And those tools that just used a bunch of random variables were actually just as good as the tools that have been validated across many settings and are frequently in clinical forensic use and used by the courts. And so that sort of, it calls into question how important the complexity of the statistical modeling is. Probably what's going on is just that we know there are some factors that tend to be very associated with violence. And, if we include those things in our model, whether it's a formal statistical model or sort of, again, our clinical gestalt, and we're accounting for those, we're probably going to arrive at roughly the same conclusion. And probably the more complex models are not getting us that much more. But this is fairly controversial in the literature. Just to say a little bit more about specifics of actuarial tools. So there are a number, as I mentioned, that are in forensic and legal judicial practice. Some examples that you might have heard of or might come across in your reading are the cover, the clinical assessment of violence risk, and the VRAG, the violence risk appraisal guide. The cover was actually designed based on the MacArthur violence study, which I'll come back to in just a minute. All of these tools were developed with the use of fairly large and sophisticated data sets, and then again, validated in multiple populations over the years. The static 99R is another actuarial tool that's actually used to estimate likelihood of sex offender recidivism for adult male sex offenders. And that's very commonly used in that particular area of forensic practice. The Brosette violence checklist is actually one that you may come across in your clinical practice. It's probably the only one of all the actuarial tools I'll mention that you might actually come across clinically. We actually use it in our hospital, and it's fairly helpful. It's a simple tool. You can see it. It's here on the screen. It's 6 items that are rated just on presence or absence, and it's designed to be used for patients who are being admitted to an inpatient psychiatric unit of any kind. So typically the rater is either an emergency room nurse or the inpatient nurse who first has contact with them. And the tool is designed to predict violence in the inpatient unit, and it's been validated in many settings and shown to predict that with a fairly high degree of accuracy. And so the nurses will rate whether or not the patient has confusion, irritability, if they're boisterous, they're physically or verbally threatening, and if they're attacking objects. And a score of 0 indicates low risk, a score of 1 to 2 is moderate risk, and anything greater than 3 indicates significant risk. And I actually have found this tool fairly helpful. In fact, when I get called in the middle of the night from the emergency room about potentially admitting a patient, the nurses will always present to me the patient's Brosette score. And it's fairly helpful for me, especially like at 2 o'clock in the morning when I'm having trouble kind of synthesizing all of the data myself, thinking about what their risk is and thinking about whether, when I accept the patient, if they're going to need a one-to-one or some altered level of observation, having the Brosette score is actually really helpful in making that assessment. So that's one of the few places actually where you may find an actuarial risk assessment tool for violence helpful in your practice. Another tool that's just worth mentioning, I mentioned that structured professional judgment tools are kind of a hybrid between our clinical gestalt or clinical risk assessment and these actuarial tools or the formal tools where you're assigning someone a number and then you can estimate their probability based on that number. The HCR20 is a structured professional judgment tool that's in fairly widespread practice in forensic settings. It's kind of comparable if you guys have ever done the Columbia suicide rating scale. It's kind of comparable to that. And the Columbia, I think, is a good analogy on the suicide risk side for what a structured professional judgment tool looks like on the violence risk assessment side. They're fairly comparable. So when you go through an HCR20, you estimate with a scale, so 0 to 2, absent, possibly present, or definitely present, whether or not each of these variables, how that variable applies to the patient. And it's in 3 domains, so past, present, and future. And you can see the items here on the screen. They're all things that are fairly relevant to the violence risk assessment and also more detail than you usually would go through in just your average clinical risk assessment. This is a tool that I've employed, for example, as I mentioned earlier, in making a decision about whether to release someone on conditions when they've been in a forensic setting for, let's say, years, and you know a lot about their violence history. You have a lot of information to work with, and you want to present it in a fairly structured way. So having talked a little bit about the different approaches to risk assessment, I just want to comment briefly on the limitations of risk assessment. And I think probably the most important one to note is that, in general, we're just bad at it. We're really bad at predicting rare events generally, not just violence. This applies to suicide as well. And it's also really important to note that anytime we're employing an approach that incorporates our subjective judgment, not just sort of a totally empiric assessment of variables, and in reality, even empiric assessments of variables almost always involve some degree of the rater applying their own judgment to decide whether a variable is present or absent or to what degree it is. All of these are subject to bias, and there's fairly good literature showing that we have all sorts of sort of systematic errors that we make in conducting these risk assessments. For example, we tend to over-predict violence risk in minorities. We tend to under-predict violence risk in women. We tend to under-predict violence risk in people who the rater subjectively finds attractive, for example. So there's all sorts of biases that can come up in these risk assessments, and I think are really important to be aware of. And then, as I mentioned earlier, even our best methods are providing only an assessment of a group level risk. So you can't truly know someone's individual risk. You can only say at best that they belong to a group that on average has a higher or lower level of risk. And this is true, by the way, not just for violence risk assessment, but also for suicide risk assessment. And so I think it's really important to remember that when you're conducting these assessments and presenting them to, to other decision makers or clinicians. And it's also important to note that in your documentation, because it is an important distinction. And so I always try to include that wording in my risk assessments, whether they're about suicide or violence risk assessments. By the way, guys, feel free to jump in at any time with questions. I'll leave some time for questions at the end, but I know this is kind of a lot of content. So if anyone has questions as we go, please feel free to jump in. I mentioned earlier about the MacArthur Violence Risk Assessment Study, and I wanted to come back to that just for a moment because it is kind of a landmark case in this area that informs a lot of our thinking about violence risk in patients with serious mental illness. So this was a study that looked at about 1,100 psychiatric inpatients as they were released into the community and followed them every 10 weeks for a year after they were released, specifically to look for violent behavior. And they evaluated that both by patient self-report and by all the collateral they could reasonably get, so arrest records and family member report. And they compared that to about 500 patients who lived, non-patients, individuals who lived in the neighborhoods where the patients were released to. So there was a fairly robust control sample. And the really important finding to know about from this study is that patients with major mental illness were no more likely than their non-mentally ill counterparts to be violent unless they also use substances. And so substance use in this context, as we kind of already knew, but it was confirmed in the study, is probably one of the most important risk factors for violence in the patients that we worked with. Substance use roughly doubles the risk of violence, which I think is important to know about, not just because it informs our understanding of patients' risk, but because it's also a very modifiable risk factor, right? It's something that we treat all the time. And so I think it's something to be very attentive to and something that we should really be focusing on in all of our clinical practice, but especially when we're thinking about violence risk. Also notable from this study, there were many interesting findings from the study, and I would encourage you to look at it if you get a chance, but another notable finding is that among folks with serious mental illness, the most likely targets of their violence were either family members or friends. And so I think it's, just to go back to that for a second, worth noting that this is in contrast to public perception, which is that patients with mental illness are more likely to be violent. This study really showed that that is not the case, again, with the exception of substance use. So just to talk a bit about risk factors for violence. So we'll just go through these. I think that'll probably be the most efficient way to cover this. So the most important risk factor for violence is a history of violence. This is something you guys have probably all heard. But it's worth saying because the clinical implication, right, is that if you have a patient who you're doing a risk assessment for, you really want to get a detailed history of whether or not they've ever been violent, and if they have, what the context for that was, and sort of what the nature of the violence was, how often it's happened, et cetera. And so things like Steve mentioned earlier, so like weapons history, and then also considering arrests, assaults, again, what the context has been, was it provoked or unprovoked, how seriously was the person in question hurt. You really want to take a detailed history. In addition to history of violence, there are demographic risk factors that can be relevant to know about, but again, I think less about these in a clinical setting because they're not something we can modify. So helpful to know about, but not something we necessarily can intervene on. But younger male patients are more likely to be violent. Substance use, as I just mentioned, some types of psychotic symptoms. And so here the evidence is less robust. And all of the risk factors that I'm about to mention, I'll say that the evidence is a little bit less robust, but there's some association between some types of psychotic symptoms and some types of violence. You'll notice I'm using a lot of sums because the literature, as I mentioned, is somewhat mixed and also not terribly convincing, in my opinion, in a lot of these areas, but positive symptoms do tend to increase risk more than negative symptoms. In fact, negative symptoms may decrease risk, which probably from a clinical perspective to many of us is not surprising. of the positive symptoms that your patients might be experiencing, ones to pay particular attention to are things like paranoia or threat control override symptoms. So in other words, delusions that they're being controlled, or that someone is, putting something in their body, poisoning them. Those kinds of symptoms do probably tend to increase violence risk. In the same way, command auditory hallucinations, obviously, if those command auditory hallucinations are telling patients to hurt others, can increase violence risk, and persecutory delusions can also increase violence risk. As I mentioned, negative symptoms probably decrease risk. Mania is an important risk factor, especially for impulsive agitation and resultant violence. That's something that clinically I think is probably unsurprising to any of you who have ever taken care of a manic patient. Cognitive impairment actually can increase risk. And there's some indication that depression, some types of depressive symptoms, especially hopelessness, can increase violence risk, especially if you're thinking about crimes like murder, suicides. Those are usually in the context of severe depression. Antisocial personality disorder and psychopathy, which is a bit out of the scope of what I am going to cover today, but there is an association between psychopathy and or antisocial personality disorder as measured by some standardized tools like the Hare psychopathy checklist, and the risk of violence or criminality. And that is an important distinction. In this talk, I'm focusing specifically on violence and not more generally on criminality, because I think criminality is much less applicable to us as clinicians. And so the difference is relevant in that literature around psychopathy and antisocial personality disorder, and keep that in mind if you're ever looking at studies that look at association between antisocial personality disorder and violence or criminality. Look at what their outcomes are, because some of them are less clinically relevant, I would argue. So coming back to clinical violence risk assessment, which is what I said I wanted to focus on here, and kind of putting yourself back in my chair when I'm sitting with this patient who's telling me that he's fantasizing about hurting his ex-stepfather. So obviously you want to ask the patient about homicidal ideation, and once the patient has disclosed that symptom, you want to get as much detail as you can about exactly what they're thinking about doing and if they have a plan. If homicidal ideation is present, this should really be your trigger, I think, for doing a clinical violence risk assessment. In the same way that if the patient has suicidal ideation, you want to be kind of switching into let's do a suicide risk assessment mode. As you're asking about history of violence, if you can get collateral, that's really, really helpful. Obviously, that's not always possible, but asking patients' friends or family, or even getting past records, that can provide more unbiased information, just like any other clinical assessment you might do. And then from there, you want to be thinking about determining the appropriate level of care. And as a part of that, it's really important to emphasize, just like with suicide risk assessment, you want to identify the relevant diagnoses, if any, and then create a violence prevention plan. Because the diagnosis that you think is informing the symptom, if there is a diagnosis, and of course there may not be a diagnosis that's directly relevant to the homicidal ideation, but often there is. And if there is, that's something that you definitely want to be considering how to intervene on most effectively. And here I'll just take a brief foray into case laws. We're thinking about sort of treatment planning, and I'll just mention the legal framework around that. I would be remiss not to mention the most relevant case law, which I'm sure all of you are familiar with, which is Tarasoff versus the Regents of the University of California. This was a case which, for the residents, this will likely come up on a prior board or exam for you at some point. So this was in 1976. Prasenjit Podar was a graduate student at the University of California, Berkeley, who had dated Tatiana Tarasoff, and then she broke up with him. He became obsessed with her, started stalking her, became extremely depressed, apparently developed some psychotic symptoms, and disclosed to his therapist at the University of California that he had a plan, an intent to kill Tatiana Tarasoff. And his therapist applied for him to be committed because of his homicidal ideation. And he was taken to the hospital and he was examined, and the evaluators apparently thought that he was fairly rational. They didn't hold him. And then he terminated care with that therapist and was lost to follow-up. And then several months later, he completed that plan and killed Tatiana Tarasoff. And so her family sued, arguing that the therapist had a duty to tell her that she was at risk, which he had not done. And the Supreme Court of California, which was the highest this case went, so technically it's not necessarily binding on us in Idaho, but it's still worth knowing about, and is considered sort of the standard of practice in psychiatric care. The Supreme Court of California held that when a therapist determines or should determine that his patient presents a serious danger of violence to another, he incurs an obligation to use reasonable care to protect the intended victim from danger. And you'll notice that the wording here is to protect. And so all of this often in textbooks and in clinical practice is construed as a duty to warn. I think it's actually better understood as a duty to protect. And the reason I say that is because as a psychiatrist or any mental health provider who's caring for a patient in this situation, you really have two options for how to execute that duty to protect. One of them would be to directly warn the intended victim. And so that's the column on the right-hand side here. And probably many of you guys have been through this process. If this is the way that you choose to discharge that duty to protect by warning the potential victim, then you want to notify the victim if possible, and then also notify law enforcement in whatever the relevant jurisdiction or jurisdictions are. And it's really important to think about where you want to contact law enforcement, because oftentimes the intended victim is not in the same jurisdiction as the patient you're seeing. And so in that case, I would advise you to talk to both law enforcement in the jurisdiction where the patient is and also where the intended victim is, if that's something that you can determine. And then oftentimes law enforcement will take care of contacting the victim, but you should either do that yourself or confirm that they're going to do that. And then I also would encourage you, if you're going to execute a duty to warn, to let the patient know that you're doing that, if it's safe to do that, because that will help you maintain rapport with the patient to the extent that you can, and hopefully keep the patient in your care, which can be important for mitigating their risk in an ongoing way. And then of course, obviously you want to document really clearly who you talk to and when. But going back to the idea of a duty to protect more broadly than just a duty to warn, there's another way that you can discharge your duty to protect, which is to hospitalize and therefore prevent the patient from being able to act on that homicidal ideation. And this is often actually in clinical practice how we choose to execute our duty to protect. And so if a patient discloses to me that they're considering hurting a specific victim and I determine that the risk is imminent, and I've just included up here and I'll let you read for yourself what that means in terms of Idaho's statute. It's probably similar to other places you guys have practiced. If you've practiced in multiple places, like for example, for those of you who were in Seattle for a few years, the wording is fairly similar, but essentially the patient needs to demonstrate an imminent risk based on their behavior. And you think that it's very likely that they're going to harm an identifiable victim, or even harm someone who you can't necessarily identify, but you think there's a high risk that they're going to go out and hurt someone. Then you can hospitalize the patient, including involuntarily, under this statute. And if you do that, it doesn't necessarily prevent negate the duty to warn, but you don't necessarily have to do it right away. And in clinical practice, what I've done in the past, and I think what often we end up doing, is hospitalizing the patient while they're acutely homicidal, and then continuing to reevaluate whether there is a duty to warn, and reevaluating that again at the time of discharge from the hospital, because at that point, if the patient's HI has resolved, there may or may not be a duty to warn depending on what exactly the threat was. The big caveat with this is that you really want to make sure that you're providing a very clear handoff to either the emergency room or the admitting team or both, so they know what your concerns are and they know whether there is going to be a duty to warn, or what they'll need to assess before the patient leaves to determine at that point whether there's a duty to warn. And I just want to, I wanted to include this because obviously with forensics and whenever you're thinking about legal regulation of psychiatric practice, there can be variation from jurisdiction to jurisdiction. And so I think it's important for all of us who are practicing in Idaho to be familiar with Idaho statute. So not every state actually has this duty to warn or duty to protect codified in statute. Idaho actually does, which I think for us is very helpful. This is the definition per the Idaho code. I think the most relevant section that I'll draw your attention to is that the patient has to have communicated a threat, and the patient has to have the imminent, the apparent intent and ability to carry out the threat. And so even though the wording in the statute is the duty to warn, I think it actually does encompass a duty to protect sort of by default, because if you hospitalize a patient, right, then they don't have the ability to carry out a threat, presumably, assuming they don't elope or something like that. And so it's helpful, I think, just to have this this legal context in case this ever comes up for you in the future. But it's pretty similar to, I think, the recognized standard in other states. Just to comment briefly, and I won't spend too long on this because it's not really the focus of this talk, but whenever you're doing a violence risk assessment, as I mentioned before, one of the really important things you want to identify as a clinician is what the modifiable risk factors are. And so as you're coming up with a treatment plan, whether or not that includes hospitalization or a duty to warn, you also want to be identifying, again, the relevant diagnoses and then thinking about specific interventions, including medications that can be helpful to mitigate their risk. There is no FDA-approved medication that reduces risk of violence or aggression, but there is some data for some medications, which I guess many of you guys are probably familiar with. Again, you want to identify and treat the relevant diagnoses. And if you're concerned about violence risk specifically, and you're wanting to pick a medication that both treats the diagnosis in question and also may have some additional benefit in reducing violence risk, I would encourage you to think about one of these options. So Clozaril, again, if it's indicated for the diagnosis, it's actually been shown to directly reduce violence risk in patients with psychosis. And so there is really good data for that. It's one of a million reasons to consider using Clozaril. Lithium, similarly, there's some evidence that can reduce aggression and violence, especially in some populations like patients with intellectual disability or psychosis and a comorbid mood disorder, an indication for lithium. There's some evidence as well for beta blockers, especially in patients who have a history of traumatic brain injury, antipsychotics, again, if they're clinically appropriate. This is well outside the scope of this talk, but we often obviously use antipsychotics to decrease risk of violent behavior in patients who have neurocognitive impairment with associated behavioral disturbances and a history of violence resulting from that disease process. So it's something to consider. And then Depakote, there is some evidence in several populations, including populations with some kinds of cognitive impairment, that can reduce risk of impulsive violence. Again, the evidence on that is a bit more mixed, but we do use it for that reason sometimes. So coming back to the case, so as you'll recall, the patient disclosed that he felt angry towards his stepfather for most of his life. He sometimes had fantasies about acting on those feelings of anger, but he denied that he had any plan or intent to act on them. I did a more detailed assessment of his violence history, and he denied that he had any significant history of violence. Again, no arrests, but he had gotten into some fights as a child, none recently. When I asked him what prevented him from acting on his fantasies, one of the things he said was that he didn't want to get in trouble, he didn't want to go to jail. He recognized that he probably would if he did something like that, so that's a protective factor. He actually was coming to me asking in part for treatment for these symptoms. He viewed them as a problem. He viewed his perseveration on his anger as something that was negatively impacting his life, and he was hoping that treatment would reduce some of those symptoms and that he would not have these violent fantasies coming up for him so much going forward. So for the sake of time, I'll kind of walk you through my risk assessment at that point. So I identified some of his static risk factors, his dynamic risk factors, cannabis use being one of them. Also difficulties with mentalization and empathy. I mentioned that he often felt himself getting angry in situations where he felt like people weren't reciprocating his attempts to form social connection. I think that is very directly related to his autism spectrum disorder. And he recognized that that was a deficit he really struggled with, and he'd actually worked on in past therapy, but still felt frustrated because he just had never really been able to completely correct or change, maybe would be a better word. And so that was something that I viewed as a dynamic risk factor. Protective factors, again, he was engaged in care, asking for treatment for these symptoms, denying a plan, and able to appreciate the consequences of his actions. All important protective factors when you're thinking about risk of violence. So overall, I didn't think that he represented an imminent risk to his stepfather or anyone else. And we created a treatment plan that involved restarting an SSRI. I engaged with him about his cannabis use in a motivational interviewing framework. We actually spent a fair amount of time on that. And he was able to make a plan to cut back significantly on his use, not stop it completely, but to cut back. I referred him to individual psychotherapy, again, with a goal of not only working on the depression, but also some of those difficulties that he continued to have with mentalization and empathy. And then we reviewed his suicide and violence safety plans, and we made a formal plan that included some patient-driven interventions. He volunteered that he often felt less irritable and aggressive when he was engaged in more exercise. And so we made a plan for him to increase his exercise. He thought that would be helpful. And that was where we left it after the first visit. I continued to see him over the course of about a year. And about a year later, I saw him back. He had missed a few appointments in the interim, although previously he had been coming in regularly every month. We'd been titrating sertraline, and that helped a fair amount actually with his mood and irritability. His PHQ and GAD scores had come down significantly. He felt like his function had improved. But at this particular visit, he had some psychomotor agitation. He described feeling more irritable. He was more angry. He just looked different than I had seen him at previous visits. He endorsed some increased passive suicidal ideation, but still no active suicidal ideation or plan. He told me that he'd been hitting his head, which was a form of self-harm he had engaged in as a child, but not so much as an adult. And he, over the past few weeks, had actually gotten into a fight with his brother, who he was living with. Neither of them was hurt, but he actually took a water bottle and threw it at his brother. And his brother, he sort of narrowly missed his brother. And then there was sort of some pushing, and one of them shoved the other into a wall. He had pretty clearly been the provocateur in this fight. This was something that they had both sort of done as kids, but not recently within the last few years. So this was different for him too. Most concerningly, he told me that he'd been feeling increasingly angry at his stepfather, and he'd been thinking about getting a plane ticket to the state where his stepfather lived to quote unquote put an end to it, because he felt like that was what his stepfather deserved. And he was pretty perseverative on this. It was hard to get him off this topic in this interview. When I asked him pretty directly if he thought he would be likely to act on these thoughts, which is an important question to ask when you're assessing risk of violence, he wouldn't give me a direct answer. And he also couldn't cite any protective factors. Again, when I first saw him, he was able to clearly cite a number of protective factors. And this time he really just couldn't tell me anything. Basically, it was sort of I don't know, at this point, I don't know if there's anything that's stopping me from doing it. So for the sake of time, I'll just sort of let you guys answer this in your own heads. But hopefully at this point, you're thinking about a lot of the risk factors that we were just thinking about and talking about. And he obviously has a number of factors that are concerning. So at this point, my clinical risk assessment, static factors again are unchanged. The dynamic risk factors I thought were some were similar to at my first assessment, but the homicidal ideation with plan obviously was different and very concerning. He was not able, as I mentioned, to identify any significant protective factors, and I was pretty concerned based on my my risk assessment and my understanding of his history and the factors he was describing. So at that point, I felt like he was a possible imminent risk, and I felt that my duty to protect applied. And so we actually were able to navigate a voluntary hospitalization for this patient. Again, I think he did have some preserved insight and on some level viewed these symptoms as a problem. So I walked with him over to the emergency room. I discussed his symptoms with both the emergency room docs and the admitting team. He was hospitalized for about 5 days. And he was started on risperidone to augment his sertraline, and he found that really helpful. He had symptomatic improvement, resolution of his homicidal ideation, not immediately when he went into the hospital, but around day 3 or 4. And before discharge, the admitting team actually had a family meeting, which did not involve his ex-stepfather, but did involve his mother, who was still in contact with the ex-stepfather, and his brother. And they were, he was able to talk with them about his thoughts, which they had not previously known about, and they all found that helpful. And he was discharged back to stay with them. And so the admitting team, the inpatient team at that point, reassessed the imminence of his risk and his homicidal ideation, and they felt like there was no duty to warn at the time of discharge, because he at that point was able to say again that he had no plan or intent to go and harm his ex-stepfather in any way, and was able to cite a lot of protective factors, and also felt like the symptoms that were leading to those feelings of irritation, agitation, had more or less completely resolved. So I'll just talk a bit about what I think is the future of risk assessment, and I won't dwell too long on this for the sake of time. Clinically, I think there's probably not going to be a lot of change in how we as clinicians do risk assessment over the next decade or so. Again, we've known about the risk factors for violence for a long time, and our thinking about that has not significantly changed, even in the face of all of these new, more sophisticated statistical tools that the courts sometimes use. But that being said, there has been a sort of flourishing of the development of these advanced statistical tools to try to predict risk, which is not terribly surprising when you think about our desire in general as a society to try to predict everything we can. In that context, there have been a number of applications of what I think could be reasonably classified as machine learning to the prediction of violence risk, although we haven't always necessarily recognized that it's that, and the definition of machine learning is somewhat disputed. But I would define it, and I think this is a fair definition within the statistical learning community, as the use of algorithms that use data, especially large data sets, to refine predictions or classifications. And of course, that really is the sort of fundamental task of risk assessment, especially when you're talking about risk assessment in a forensic setting. And one of the projects that I did in my forensic fellowship was to actually look at a number of specific kinds of actuarial tools to predict risk, and then assess their methods to determine whether they were using what might be understood as machine learning to actually develop their tools. And as you can see from my table, so this is 13 tools that I identified that met my inclusion criteria. In other words, prediction of violence risk in a systematic and actuarial way. And of those, 8 actually used methods that could be fairly classified, I would argue, as machine learning. And increasingly, that's been the case, and again, with higher and higher degrees of sophistication as these tools have been developed over the past few years. In fact, there was at least one that I was able to identify developed within the past few years that used deep learning to try to predict violence risk. And I think we're going to see more and more tools moving in that direction. That being said, as you might have gathered from my somewhat skeptical stance towards actuarial tools in general, there is no evidence that these are better, I would argue, and I think the literature would largely support, than our clinical judgment in most cases. And I think we should all be wary about tools that purport to use these advanced statistical methods to tell us whether our patients are going to be violent or not. So in summary, just main takeaways: always assess for homicidal ideation. I'm sure you guys are all already doing that. When homicidal ideation is present, think about conducting a violence risk assessment and think about how you want to do that. I would encourage you to evaluate both static and dynamic risk factors, but focus on the risk factors that are going to be most modifiable. Determine the appropriate level of care and discharge your duty to protect, either by warning or hospitalizing, if that's indicated. When in doubt, consult a colleague. Don't ever be afraid to do that. Often these cases are complex. They involve a lot of decision-making that makes us uncomfortable, and that involves risk not only for our patient, but for other people, which kind of ups the ante. So always consult a colleague if you feel like you're in doubt or just want some extra support. That's usually a good idea, no matter what level of training you are. And then another important piece of things is don't forget to conduct a detailed suicide risk assessment as well as a homicide risk assessment for patients who have HI, because all of your patients who are at risk for violence are also at increased risk for suicidal behavior. And so pay attention to that as well. And those are my references. And I think I managed to leave 3 minutes for questions. So not as much time as I'd hoped, but anyone have any questions, thoughts about the case?
I just want to say that I loved how you included in the risk assessment that they belong to a group of a higher or lower risk factor. Because I find that, I mean, risk is so variable from, like in this case, from session to session. And to just label somebody at high or moderate or low risk, it's like they're at low risk right now if A, B, and C doesn't happen, or they're at high risk, you know? And so yeah. I just really appreciate that. Thank you.
Yeah, that's a really good point.
Hey, Liz. Hi.
Yes.
This Dr. Listen, really great talk. You know, I really like your point about the actuarial stuff versus the more gestalt. And one thing that's really tricky, though, is even though that's true, like in any kind of a forensic or any kind of legal setting, the actuarial stuff just like shines brighter.
Totally.
And it's kind of hard to educate and point out to people that they're really just kind of equivalent because they see those hard numbers and they just really like that.
Totally agree. Totally agree. And even I, as you can probably tell, a serious skeptic about a lot of the actuarial tools, am just as inclined to pull out a static 99R or a HCR 20 when I'm, trying to defend my decision making around releasing patients, in a forensic setting. And so I'm sure you run into this much, much more often than I have. And so, yeah, I definitely appreciate your perspective on that. And I agree, the courts and, other decision makers really prefer those tools. All right, well, thank you guys for your attention and questions. If any of you guys have follow-up questions, please feel free to get in touch. Otherwise, thanks again for inviting me to talk about this, and hope you guys are all taking care.